Okay. Good afternoon, everybody. It is my pleasure today to welcome my colleague at the BCCDC, Kathleen McLean. Kathleen's background is in chemical and biological engineering here at UBC, and then she did a Master's of Public Health at SFU. She used to work in the School of Occupational and Environmental Health here. She has worked in the school up at SFU as well, and for the past couple of years, she has been working on a bunch of different research related to air quality at the BCCDC, and she's going to tell you some about this project that she mostly leads today, which is the BC Asthma Monitoring System in the context of what happened in British Columbia over the past summer. So welcome, Kathleen.
Thanks very much, Sarah. I'm glad to be here. So the BC Asthma Monitoring System, we call it BCAMS for short, and it's a passive surveillance system that tracks asthma-related health outcomes and measures of exposure to forest fire smoke across British Columbia. Just before we get started, raise your hand if you spent at least part of the summer in BC, and then leave it up if you felt the effects of forest fires firsthand. So we have a lot of hands, which is not surprising. So this forest fire season started early because we had a warm and dry spring after a winter with less snowpack than usual. And we had drought conditions throughout much of the province and some very hot weather, both of which combined to produce, we had some intense conditions, lots of smoke, many fires. And some of the fires were, impacting local communities, and properties had to be evacuated and that kind of thing. So, and this forest fire season was also very expensive. I've learned this year that this headline here can be reused every time we have a severe fire season, because the province always budgets as if we won't have a severe fire season. And the reasoning is that they don't want to tie up funds in case they don't use up all of the firefighting budget. But they've overspent the budget for 9 out of the last 10 years. So maybe they need a new approach. We'll see. All right, and who was in the Lower Mainland at the beginning of July? So a few hands. So for those who weren't here, we had a major smoke event that affected the whole Metro Vancouver region, the Fraser Valley, and Vancouver Island. And what happened is there were several fires burning up in the Pemberton area, and one in particular, the Elaho fire, grew really rapidly one night, sent a whole bunch of smoke up over the mountains. The smoke was pushed out over the ocean a bit, and then it was pushed east over top of Metro Vancouver and up into the Fraser Valley, and it kind of moved from the ocean into the Fraser Valley over a couple of days. So I've lived in Vancouver for over a decade now, and I've never experienced anything like that smoke event, and I'm sure that's true of many people who live here. But it's important to acknowledge that smoky conditions like that are common summer occurrences in other parts of the province, like the interior and the north. So the populations there have to deal with conditions like that on a much more regular basis. Definitely more often than 10 years or so. So these are the years in the recent past when we've had more severe fire seasons. So you can see that 2015 is comparable to these other years in terms of total fires and the hectares burned. And so with the effects of climate change affecting weather patterns and BC's forests, we've been expecting to see longer and more severe fire seasons happening more frequently. And so the recent past here definitely looks consistent with those predictions. So why should we be concerned about more severe fire seasons? So obviously fire is dangerous all by itself, but then it also produces smoke, releases a whole lot of particles into the air, and this has noticeable effects on health at the population level. Mostly respiratory impacts, also maybe cardiovascular and a bit. So you can think of, if you think of kind of an inverted pyramid on this page, so the milder outcomes like increased respiratory symptoms and dispensations of reliever medications affect a larger proportion of the population than the more severe outcomes like hospital admission or death. And in a surveillance context, when we're tracking things like this, this means we expect less severe outcomes to have a stronger signal than more severe outcomes, but we also might see more noise in the data. Okay, so after the severe fire season of 2010, medical health officers in BC recommended the development of a province-wide passive surveillance system that tracks health effects associated with exposure to forest fire smoke. And so Sarah Henderson and Angela Yao at the BC Centre for Disease Control began developing just such a system. And then BCAMS was operational for its pilot year in 2012, and it's been running each summer since then. And the aim with BCAMS is to provide information that supports decision-making in local health authorities. And the output from the system is a weekly report for each regional health authority in the province. So there are 5 health authorities in BC. For anyone who's not familiar, there's Vancouver Island, Vancouver Coastal Health, Fraser Health, Interior Health, and Northern Health. The one here on this map is Interior Health. And within the health authorities, there are health service delivery areas. So there's are smaller regions within the health authority, and there's 3 or 4 health service delivery areas in each health authority. So each weekly report from BCAMS includes a summary page describing BCAMS, and then a summary map of the health authority that I just showed. So the summary map, each health service delivery area is colored, and it shows whether anything unusual was detected in the previous week. So green is normal, yellow and red and orange are not normal, and I'll go into that a bit more in a minute. The blue dots are PM 2.5 monitoring stations, and the black X's are fires detected by satellite. And then also in the report for each health service delivery area, there's a summary page that shows health outcome information at the top, and we have exposure information at the bottom. And I'll be coming back to this figure in a minute. So the way the system works is that we take daily counts of an asthma-related health outcome, and including historical data for as far back as we have it, and we feed that information into a disease outbreak detection algorithm called FIDO. FIDO was developed at the BCCDC, and it performs iterative regression to determine the expected distribution of the count data based on historical, seasonal patterns. So we take what we saw happened in the past, feed it into an algorithm, and try to predict what we would expect now. So back to this figure. So the black line here are the expected counts, and the gray bars are weekends and holidays. So you can see there's a pretty consistent weekly pattern in what we would expect based on historical trends. So counts are higher on Monday, they kind of decrease throughout the week, and then they're much lower on the weekends. So the colored bars show the actual counts. So that's what was actually experienced. And when the actual counts don't deviate too much from the expected counts, then we call this normal and color the bars green. But if the expected counts deviate a whole bunch from, or the actual counts deviate from the expected counts a bunch, then we color the bars differently. So if the actual counts exceed the 95th percentile of the expected distribution, then we call this unusual and color the bars yellow. And if the actual counts exceed the 99th or 99.9th percentiles of the expected distribution, then we color the bars orange or red, and we call this rare or very rare. And any time that the counts are higher than expected like that, we call this an excursion. So you'll hear me use that word some more. All right, so with the health outcomes, we have 2 health outcomes that we use for BCAMS. So we have asthma-related physician visits from the BC Medical Services Plan's billing data, and we also have dispensations of salbutamol sulfate from the province's PharmaNet system. Salbutamol is a common medication prescribed to relieve symptoms of asthma or COPD. So both of these health outcomes have been studied in BC and elsewhere, and they're significantly increased when there's exposure to forest fire smoke, and they're well suited to use in a surveillance system like this. But they also have some cons, each of them different cons. So I'm just going to go through those a little bit. So the MSP billings data, so that database is populated over time as physicians submit billings. So someone goes to the doctor, they have a visit, and then that doctor's office submits the billing to MSP. But all these offices do so on a different, varying schedules. So some practices submit billings daily, some others might submit billings weekly or less often, and so there could be several days from when a visit occurred until when that visit shows up in the MSP database. So this affects when we can detect excursions using the MSP data and how confident we are that FIDO has detected these excursions accurately. So I have a bit of an example of what this looks like. So these are data from last year, and you can see at the bottom there's a few spikes in PM 2.5 that happened, and at the top we have the daily counts, and you can see that if we're using visits claimed within 1 day of when the visit occurred, the data are kind of sparse and we're not really sure what's going on there. Day 2, you can see the data become a bit more or a bit less sparse. By day 3, again, but these excursions that are popping up, they keep changing, so we're not really sure what's really going on. Same with day 4, everything changes again. And day 5, and here, with day 5 and day 6, you can actually see we've got 3 excursions happening, but they're actually happening in the same place 2 days in a row. And then day 7, you can see we still have these same excursions. So we have to wait 5 days before we can be sure of the data coming out of FIDO. So that means that if we're producing a BCAMS report, it's only talking about what happened 5 days ago and earlier. Now, with the PharmaNet data, so all prescriptions dispensed in the province are entered into the database as they're dispensed. So all the pharmacies are hooked into the system. And so here we have dispensations the day after all these medications were dispensed, and you can really see there's a strong signal right away. And this is great, except that we only receive data from PharmaNet weekly with a 1 to 2 week lag. So that means if we're producing a BCAMS report, we can only talk about what's happening a week or 2 weeks ago, which isn't very useful in a surveillance context. So we only distribute BCAMS reports using asthma visits from MSP at this point. And we've been trying to get daily data from the PharmaNet system, but it's operated by a third-party vendor, and they want a lot of money to release daily data from the system. All right, so that's the story with the health outcome side of BCAMS. And so now I'm going to talk a bit about the smoke exposure metrics that we use. So as I mentioned earlier, forest fire smoke contains lots of small particles, so it's common to use fine particulate matter concentrations, or PM 2.5, as an indicator of smoke exposure. And there are 4 exposure metrics that we use listed here, and I'm just going to show an example of what these data sources look like from July 7th. So the first one is we have a bunch of PM 2.5 monitoring stations scattered throughout the province, and you can see that here, but you can also see that there aren't monitors everywhere in the province, so these data don't really provide a complete picture of air quality everywhere. So we also have a forest fire smoke exposure model that was developed at the BCCDC, and this model estimates daily PM 2.5 in all populated areas of the province. So there are lots of little squares everywhere in the province here. And to calculate these estimates, the model uses measured PM 2.5 from the monitoring stations, but it also uses remote sensing data collected by satellites on the locations of fires, the size of fires, locations of smoke, the amount of smoke, and also the venting index. All right, and then we also include data from 2 forest fire smoke forecasting systems, Blue Sky and Firework. So these models use the type of remote sensing data on fires that I just mentioned, but they also use meteorology forecasts to predict where smoke is going to end up in advance in the future. So these services for July 7th would have been predicted the previous day on July 6th. And for each of these data sets, we have a method to calculate an average concentration for each health service delivery area, and then all these daily average concentrations show up on the health service delivery area summary pages at the bottom. All right, so this is what was going on in the province according to BCAMS during that early July smoke event that we all, or a lot of us, experienced. So we saw increases in asthma physician visits throughout the Vancouver Island Health Authority, the Vancouver Coastal Health Authority, the Fraser Health Authority, Interior Health, and Northern Health also had a little bit going on. There were really fires everywhere in the province at that time. And then I've got a couple examples of what the health service delivery area summary pages looked like. So we have the North Shore Coast Garibaldi Health Service Delivery Area and the Vancouver Island North Health Service Delivery Area. And you can see the spike in PM 2.5 occurring at the beginning of July in both places. And then in North Shore Coast Garibaldi, we had sort of over double the expected number of asthma visits for a couple of days. And in North Island, there was actually a quadrupling of what we would expect for asthma visits there. And then we have salbutamol dispensations. So you can see right away, we actually have orange and red here instead of yellow and red. So that's just that we use different percentile cutoffs for the two different outcomes. And you see stuff going on everywhere in the province. And so this is sort of where we seem to get a bit of a stronger signal from salbutamol dispensations than we do with the asthma physician visits. And then I have the same health service delivery area examples there. So there were more than double the expected number of dispensations, both in North Shore Coast Garibaldi and Vancouver Island North during that early July smoke event. All right, so last summer in 2014, we had a severe fire season, and it was actually the first severe fire season since BCAMS began. So we took the opportunity to do a bit of an evaluation of the system. So what we wanted to know whether excursions are reliably occurring when PM 2.5 concentrations are high, and at what PM concentrations we can expect to see a population response. So what we did was we summarized excursions for both outcome measures. We determined which level of PM 2.5 we were going to associate with each excursion for all exposure metrics. We looked at the days with high PM 2.5, which I'll call Smoky days, and whether excursions occurred nearby in time to those Smoky days. And then we also calculated sensitivity and specificity of different PM 2.5 thresholds, which I'll explain a bit more in a minute. So we sort of chose July and August to be our fire season for the evaluation. And to assign a level of PM 2.5 to excursions, we chose the highest level during a 7-day window. So if the excursion occurred on the blue dot there on the 14th, we looked on that day, 3 days before and 3 days after, and just chose the highest level in that period and said that's the level we're going to associate with the excursion. And we did that for all of the exposure metrics. And then we use this similar method when looking at Smoky days. So we had a definition of the Smoky day, and so if the 14th was a Smoky day, we looked on the 14th and 3 days before and 3 days after and said, was there an excursion during this time or was there not? So this is just a table. I've got 2014 and 2015 data on all the slides going forward, so we can see the difference between the two fire seasons. So both were severe. But there were certainly more excursions this past summer in 2015. Also last year, we only had very rare excursions in the Interior and Northern Health Authorities, and that's really where the bulk of the fire activity happened last year. But this summer, we had excursions pretty much everywhere. There actually weren't any very, very rare excursions in the north of the province this year. And it's a very similar picture for salbutamol dispensations. Many more excursions this year, and the same story with the regions where we saw the most activity. All right, so this is these graphs show that data when we assign levels of PM 2.5 to the excursions, and then we've got the percentage of excursions with a PM 2.5 level in one of 4 categories, so 0 to 5, 5 to 10, 10 to 25, or 25 or higher micrograms per cubic meter. NA just means that we had missing data. And so you can see that last year we sort of, we definitely had most excursions had a PM 2.5 level of 10 or higher, but this summer definitely most excursions had a PM 2.5 level of 25 micrograms per cubic meter or higher. And this is the monitoring station data, and so it looks very similar for the forest fire smoke exposure model. And then with the blue sky forecasting model, last summer we had a lot of excursions that had a blue sky level in the 0 to 5 category, but this summer really most of them were 10 or higher. And then firework looks a bit different also, but a similar story. All right, so our Smoky days, that's when the monitor or model concentration for a health service delivery area was 25 micrograms per cubic meter or higher. And so there are 62 days in the study period, and we have 16 health service delivery areas in the province, so that's like 992 days that we're looking at. So 44 is really, less than 5% of the whole study period. That's how many Smoky days there were last summer, and there was actually double that this summer. And last summer, 52% of the Smoky days had an asthma visit excursion nearby, and 68% of the Smoky days had a salbutamol dispensation excursion nearby. But this summer, we saw an increase in those numbers, so 85% had an asthma visit excursion nearby, and almost 99% of the Smoky days this year had a salbutamol dispensation excursion nearby. Okay, so we use screening tests to try and answer the question of at what PM 2.5 concentrations can we expect to see a population response. So here we're looking at concentrations greater than or equal to 25 micrograms per cubic meter. So with sensitivity, so we looked, if there was a day above that threshold that had an excursion nearby to that day, then we call that a true positive, and you can see the 4x4 table or 2x2 table right there. So with sensitivity, we're calculating the proportion of days that had a PM 2.5 concentration at or above the threshold for which there was an excursion nearby. And with specificity, we're calculating the proportion of days under that threshold for which an excursion did not occur near to that day. And so you can see that we, again, had an increase in these measures from 2014 to 2015, except in the case of specificity for salbutamol dispensation excursions. All right, so another thing that we've been experimenting with this season is monitoring Twitter for tweets from BC that contain forest fire smoke related keywords like fire, smoke, smoky, etc. And this figure shows the number of tweets identified by our search algorithm each day from the beginning of June to the end of August. So you can see at that beginning of July when we had that smoke event in the southern part of the province, there was a big increase in the number of tweets we got each day. And then also at the end of August, there was a bit of a bump. And this was when the smoke from fires in Washington was affecting the interior of the province. And we have here a selection of a few of the tweets that we picked up with our search. And the idea with monitoring Twitter like this is that this may be another source of information that we can use to gauge the effect of forest fire smoke on the population. Some of them are a little funny. So we'll see how this goes. It's hard to know. I think we're getting all of the tweets that have these keywords in them, but I think people's, because we're using a geographic boundary, people's Twitter needs to know where people were when they were tweeting, and some people have that feature turned off. So we definitely aren't getting all of the tweets. Okay, so just to wrap up here, so we're seeing a really consistent population response during smoke events with BCAMS, so that's pretty encouraging. And most of the excursions are happening when PM 2.5 is relatively high, especially given the normal levels in the province. And we're seeing, especially this year when we had really defined intense smoke events, that Blue Sky and Firework are providing pretty useful information in advance. And yeah, so the timeliness of the health outcome data sets is definitely an ongoing challenge, and we'll have to see what can be done about that in the future. So BCAMS will continue, and Sarah has a PhD student who's looking at methods for how can we model the two health outcome measures together instead of treating them separately. So we'll see what comes with that. Maybe we can provide better information in the future. And so that is all I have. So we'll open it up for questions.
Great, thanks, Kathleen. We got lots of times for questions and lots of hands up, and Aaron's closest, so I'm going to give it to him.
Hi, thank you. Great presentation. I'm curious, when you're modeling physician visits versus smoke exposure for the different health regions, are you tweaking your model at all to compensate for possible differences in physician accessibility? I'm just thinking that someone has easier access to a doctor in the Lower Mainland versus, say, in the Peace Country.
Yeah, for sure. We don't actually do that. We just have, sorry, I'm just going to go back to one of these summary pages. Yeah, so we just, the counts get fed into the FIDO algorithm, and yeah, we aren't taking into account physician accessibility at all. Yeah, that's just not part of the system at this point.
Hi. So one of the tables you showed early on was like the number of fires this year and hectares burned, et cetera, compared to previous years. Mm-hmm. So by that, this year wasn't actually that much of an exceptional year. Is that correct? Because it seemed like it seemed like it was, but I mean, looking at the numbers.
Yeah, no, it's definitely an exceptional year. So just for comparison, so less severe fire seasons, there's kind of a big range in the number of fires from year to year. But in terms of hectares burned, like the less severe seasons can have less than 50,000 hectares burned. So when you're getting up into the 200,000 or 300,000 hectares burned, that's definitely a severe year. Yeah. But yeah, for sure, the total number of fires does vary quite a bit. And I think it can depend on the size of the fires that we're getting. There can be many of them, and they can be small, or there can be fewer, and they can be humongous, and that kind of thing. Yeah.
Hi, a very interesting talk. Thank you. I am very intrigued about the one of your data sources with your looking at tweets, and you mentioned something about turning off the function that tells where people are. What were the ethics approval that you went through to be able to do that?
So there is no ethics approval for Twitter because all of that information is publicly accessible anyway. And so we're using a Twitter search API that anyone can use. And so you can any of the tweets that we pulled up, you can go to the web and they're right there. So these aren't people's private things that we're accessing. Yeah.
So I'll just follow up on that. When you allow for a specific geolocation in Twitter, that's something you sign away the rights to when you press agree and you sign up. Oh, Andrea's closer.
Thank you. I'm curious how this information is used in decision making. So what do the health authorities do once they have the BCAMS report?
Yeah, that's a good question, and I actually am not sure about that. Sarah might have a bit more to say on that.
We're a bit unsure at this point as well because this is really the first year that the reports have been all that useful. So we will do an evaluation this year, and we'll go out and talk to the medical health officers to whom these reports go and ask them how they use them, what they would like to see in future. But I'm hopeful because for the first time ever, the provincial health officer asked us this year if he could please receive the reports, and one day called me up and said, "What's going on the North Island?" I was like, "I don't know." He's like, "I'm getting in touch with those guys." So it does at least provide context for people to sort of discuss the perhaps magnitude of what might be happening in the population.
Yeah, I think sometimes the people in charge don't necessarily know what's going on the ground, and so I'm sure the doctors at North Vancouver Island noticed that they were really, really busy. But yeah, having a visual representation of that can be helpful for people who aren't on the front lines.
Very valuable work at a population level. And related to the last question about decision making, there isn't a lot of information at an individual level in terms of managing the more vulnerable sector, the children, the elderly, and those with underlying respiratory diseases. So in terms of the management too, I don't know what an approach could be or drilling down to more of that.
So you're wondering about how?
Well, this is population level data.
Yeah.
So informed decision needs to be made with respect to sort of the overlooking picture, but at an individual level, when the physicians see patients, that's what I'm saying.
Oh, okay, you're asking what they might want to recommend to their patients? Yeah, okay. Well, I mean, certainly physicians are helping their patients manage their asthma. But yeah, and there was a lot of media on sort of what to do when we had the smoke event in Vancouver. So, you know, trying to stay indoors if you can, or try not to exercise outside and that kind of thing are pretty helpful suggestions. But yeah, I was at a different meeting a little while ago, and where people at Metro Vancouver, for instance, have been getting a lot of phone calls during the smoke event about, you know, what do I do, and can my kids bike to school and all that kind of thing. And so they were saying, you know, maybe we do need to have better information sources on the internet that we can point people to. Apparently, Interior Health Authority has a website with suggestions about what individuals can do when there's smoky conditions. Yeah, did that answer your question?
Hi, Kathleen.
Hi.
I have two questions. I too was intrigued by the tweets and the data, and I'm interested in the thoughts on how you would use that. Do you think that it's usable as in it's the earliest indicator of individuals experiencing both exposure and health, and therefore you might actually be able to use that for surveillance purposes? My second question, I may have missed this, I came a little late, I guess. If there is high sensitivity and specificity between the exposure and the health data, that you in the future won't need the health data and all these issues of access to timely data, and you will just be able to use the exposure data to give the various health authorities the information they need because it's so closely aligned with health effects. I'll stop there, thanks.
Yeah. So with respect to the first question, we don't really know how useful the Twitter information is going to be at this point. There's different Twitter search APIs that require different amounts of resources. So right now we get tweets within the past 7 days, but there is a way that you can get kind of everything in real time. So yeah, I mean, I'm not really sure how useful they'll be. Sarah, I don't know if you have anything more to say about the future of that, but at this point, it's mostly an experiment. Yeah. And about the, can you remind me what your second? But yeah, so yeah, if we can just use the exposure data by itself to say that something's going on, and to a certain extent that's true because, you know, we do. If air quality in BC is really good, and so when it gets to be, 25 or higher, we do see effects. But I think the health data is pretty important to have alongside. So, yeah.
So, I mean, maybe this is for Sarah as well, but I'm wondering if, so once you demonstrate that the forecasts are linked to some health measure, and of course that can continue to be improved, I was wondering if you've actually thought about sort of not dispensing, that's not a good word, getting rid of the surveillance reports in real time and just pushing the forecast, because that is what people can act on, because then you sort of, 48 hours in advance, you can say, well, we're predicting this event. We know that in the past, there's more physician visits, more medication dispense, and that's enough time to, to take some preventive measures, such as clean air shelters and making sure people have their meds and all that stuff. So is that something you're thinking about?
Yeah, I think so, maybe. But, the forecasts still kind of have a long way to go, especially when we had a summer this year when the smoke events were just super defined, and, the PM spiked, and, both forecasts, and everybody could see that PM was high. But last year, that really wasn't the case. So, yeah, Sarah, do you want to add to that?
Yeah, I do. It's something I think about a lot.
Yeah.
I completely agree, Mike. I think if we're in a position where we can have faith in the forecast, we don't need any of the rest of this. But we need to be in a position where we can have faith in the forecast, and we're getting there. So currently we have two different systems that we're using across Canada, which is Blue Sky and Firework. If you were paying close attention to some of those plots that Kathleen showed you could see that the Blue Sky predicted really high concentrations compared with the other measures that we had in a couple of times, and we know Blue Sky does that. We know that it overpredicts, but one of the problems we had with Firework this summer is that it underpredicted because the computing capacity that they had for running the system couldn't handle the number of fires that we had across Western Canada. So they just couldn't generate enough smoke to push in the model to get the kinds of concentrations that we were actually measuring. That's been corrected now. We know from other jurisdictions across Canada that Firework performed very well this summer. So it looks like we're actually getting into a position where we can have confidence in these models. And the people who, before that smoke event happened in Vancouver, Roland Stull, who leads the sort of technical side of the Blue Sky team at UBC, actually emailed me and said, hey, Sarah and Mike, we got a lot of smoke coming into the city this weekend. So, we did have that kind of heads up that this might happen. So, yeah, hopefully in a couple more years, all we can say is, look, we expect these areas to be smoky over the next few days.
Hi. So the outcome you looked at, there were essentially two measures for asthma, right?
Yep.
Is it possible that there's more sensitive, vulnerable groups that are affected more and that are not being captured? Have you guys looked into other sort of vulnerable groups?
Yeah, for forest fire smoke, other vulnerable groups might be, children, I guess, or, people with COPD or that kind of thing. But yeah, asthma is a pretty good one because people do experience, acute effects right away. Yeah, I don't know. Sarah, do you have more to say about that?
I wasn't listening.
Oh, okay. If there's anything other than asthma that we could look at, like other sensitive groups.
I would say that there's lots of health impacts of forest fire smoke. We know that, but I always say that asthma is kind of the canary in the coal mine. It's the thing that's most acute and the thing that you see most quickly. So for surveillance purposes or real-time surveillance purposes, I think asthma is still the thing to focus on.
Part of my question was that if some of the other groups are more sensitive, so is asthma one of the more sensitive ones? If you're going to see this?
I think that's probably it. Yeah, it's just a very sensitive subpopulation. It's quite a large sensitive population. If 10% of the population has asthma, that's quite a lot of people to be looking at. Okay, I wasn't paying attention because I was looking at an online question here, and that is, it's a comment more than a question, and the comment is that we had really bad fires not only in BC and Alberta this year, but also in Washington State that put a lot of smoke across the borders. And the questions about how health authorities use that information for emergency preparedness. And so Interior Health is saying that they are monitoring acute care and emergency facilities to ensure that under these conditions they're not getting overwhelmed and if they are getting overwhelmed, probably to act on it. So it's not just something that we're aware of at the BCCDC level. Health authorities are actively working as well.
Yeah, and just on that, I've actually got this slide up that shows what happened in the Okanagan at the end of August when the smoke from Washington was affecting the Okanagan. Yeah.
Okay, well, I guess if there are no further questions, we can thank Kathleen and wrap up early.
Yeah.